is the greatest gift. Contentment is the greatest wealth. Faithfulness is the best relationship. I, Dr. Bhumika, extend a warm welcome on behalf of Department of Pediatric for Mangalore Pedicon 2023. We appreciate you for taking your time off from your busy schedule to join us today. At this raising hour of the day, we will be starting with the first session. I kindly request our esteemed chairperson, Dr. Harsha Prasad L, Pediatric Hematology, to talk on the management of hereditary angioedema and C1 esterase inhibitor.
Very good morning, everybody. Hello. Very good morning, everybody. Sunday morning, you woke up so early and coming to listen to this talk. First of all, thanks IAP DK branch. Thanks to Intas Pharmaceuticals for giving me this opportunity to talk on. This is unusual subject, I would say. Many of we may miss those children with these conditions of hereditary angioedema. So we have started little late, but I will try to compensate and try to finish it in the 20 to 25 minutes of this talk. So in the next 25 minutes, I'm going to talk about hereditary angioedema, signs and symptoms, how do we diagnose it, how do we manage it, what evidence we have in terms of the management wise, and the Celestres band, which is the only one available in India for the treatment of hereditary angioedema, and we'll conclude that session. So let me start by a case where I was involved in the management as a trainee long back, maybe around 9.5 years ago. So this was a 10-year-old girl who developed sudden onset of swelling over left eye. There wasn't history, anything of allergy of note. She was feeling little bit of tingling, numbness, and then developed a swelling on the left side of the eye, left eyelid rather. She presented to a general practitioner back in UK and thought of allergic reaction and was given antihistamines. Then didn't subside. A day later returned back to the general practitioner and given short course of steroids, and was antihelminthics was also given at that point of time. However, it took 3 to 4 days to get better in spite of all these medicines. So the working diagnosis was some sort of allergic reaction. A month later, she developed abdominal pain, vomiting and diarrhea. That time, coincidentally, she has eaten something outside. They traveled outside country. I can't remember exactly, but attributed likely to be a food poisoning. Again, the same child 2 months later continued to have recurring abdominal symptoms, abdominal pain, etc. Thought of colitis, thought of migraine, abdominal migraine, and given various treatment, but never had a definitive diagnosis. One of the things they thought she is allergic to many stuff. As she grew, as she started to have pubertal changes around 11 and a half years of age, she became more and more symptomatic. More frequent swellings over the hands, legs, eyes, especially eyelid, intermittently. And the frequency of these symptoms got worse and worse, almost coming weekly. At this point of time, when she was referred from the general practitioner to the pediatrician and then to the allergist, they thought of it is likely to be a hereditary angioedema. Later, it was confirmed on the basis of the genetic studies. What they have given was, at that point of time, was initial, the tablet was available, was stanozolol, which is a anabolic steroid. Later, she was prescribed plasma-derived C1 esterase inhibitor, which made her life completely different. She's been currently on, as of a few years ago, was on regular infusion of C1 esterase long-term prophylaxis for the hereditary angioedema. So angioedema, I'm sure you all know that. Basically, the worst part of angioedema we all worry about is laryngeal edema, where they're present with a stridor and about to die, they get asphyxiated. So when we talk about angioedema, there are two broad categories: mast cell mediated and bradykinin mediated. Among the mast cell mediated, then you can say idiopathic or allergen induced. So mast cell usually presents with the with the itching, and there may be a history of allergen exposure, and itching followed by swelling, and responds beautifully to the antihistaminic steroids, adrenaline, prostaglandin, and majority of them will respond to these medicines and get better. Whereas bradykinin mediated, which I am going to talk, which is the hereditary angioedema, is generation of the bradykinin, which is a reason for the vessels to get bigger, and then they develop edema. So increased vascular permeability leading to the tissue edema, and there you don't see any pruritus, no history of pruritus, no history of urticaria. So the basic here is someone presenting with the swelling with no history of allergy, no history of itching, then you need to suspect hereditary angioedema. So other features, the onset, usually allergen induced within few minutes to hours, whereas the bradykinin takes time. So this girl had feelings, she could feel some sort of prodromal numbness, tingling, little bit of weakness, asthenia, kind of what we call it as. Urticaria, pruritus is common in the allergen induced, whereas burning sensation is sometimes, or pain sometimes can be seen in bradykinin mediated. And the allergen mediated, as I said before, respond to treatment. So these are the 8 questions we need to ask to differentiate between allergen induced angioedema from bradykinin mediated hereditary angioedema. Is it unexplained edema? Meaning, was there any exposure to allergen? Asymmetric swelling, is that just one swelling, not both the limbs are swollen up? Is there any history of unexplained abdominal pains, recurrent abdominal pains? Is there any history of family history of similar episodes? Because usually in 75% of cases you will see history of this kind of symptoms in one of the family members. Symptoms, was there any tingling, nausea, weakness, etc. before the onset of the attack? Antihistamines, adrenalines and corticosteroids, did it make it better? And angioedema without urticaria. If you answer these 8 questions, you can easily differentiate between hereditary angioedema from allergen-induced angioedema. One of the things for olden name for hereditary angioedema was hereditary angioneurotic edema. Why that neurotic came into picture? Because people used to label it as a neurosis, one of the psychiatric problem, in the sense they used to come often to the hospital with the abdominal pain, but nothing to find. And here swelling, there swelling comes and goes and etc. So they used to label it as a hereditary angioneurotic edema. So the neurotic part is not there anymore, and we know the reason for it as well. Symptoms of the hereditary angioedema typically begin in childhood and worsens during the puberty, especially in girls, because estrogen is one of the contributing factor to make it worse. 75% of them are inherited from one of the parents, meaning it is a autosomal dominant condition. So 50% chance of the baby, the subsequent pregnancies developing this problem if someone in the family having this problem. 25% of cases are spontaneous mutation, de novo mutations. The incidence is difficult to ascertain because of the pickup rate, as the awareness, as the investigative support wasn't there before. Now we got everything there, including the medicines, and the estimates is 1 in 50,000 to 1 in 80,000. they're estimating, there was a recent news article in Times of India from one of the PGI group talking about hereditary angioedema in December. They're estimating around 30,000 to 50,000 people affected with this problem in India. So it is autosomal dominant, inherited through the SERPING1, serine proteinase gene, which has got around 8 exons, and there are probably around 100 of mutations in this gene, which is leading to this problem. And there are types of hereditary angioedema, and the type 1 is usually levels are very low of C1 esterase and autosomal dominant, inherited. You get a mutation when you sequence this gene. So when do they develop symptoms? Are we missing too many cases in our outpatients? Is an infant coming with this problem into the outpatient clinic? Do they have? So looking to the onset of symptoms, so majority of the 50% of the patients present by around 10 to 12 years of age. Remaining around 100% of them present by around second decade, meaning around 20 years of age, almost all they will present with at least one or few episodes of attacks of this angioedema. It could be peripheral or it could be gut. So here, as you could see, it's usually we don't see in less than 1 year old. It's seen after a year, but average is 4 to 10 years. As the age grows, and especially the puberty, this is more and more common. Now, where are the locations of these attacks of angioedema? Where do you see this angioedema? Commonest one is skin, followed by the stomach, the GI tract, with the multiple submucosal edema leading to the common symptoms will be abdominal pain. They would have taken him to referred to a surgeon, would have done the appendicectomy, or would have referred to the neurologist, psychiatrist with these abdominal pain symptoms, because nothing else to find, though they may have vomiting. Some of them are labeled as a cyclical vomiting syndrome. So then the larynx, which is the most worrying part of the angioedema, both allergen induced as well as hereditary, and it can lead to asphyxiation and death. So this is the most worrying. That's why we need to address this issue seriously and start the process of treatment early. Then the other things are tongue, uvula, brain, the bladder, chest, the genitalia, mucosa, esophagus, all these organs are involved. If you look into the per episode analysis, the skin and stomach are seen more often. What are the misdiagnoses, how they have been diagnosed as? So the average time taken to diagnosis of HAE is around 13 and a half years as a median time. Now it's becoming shorter and shorter. It may be 3 years of late, but it used to be 13 and a half years since the onset until the patient diagnosed. So misdiagnosis as a allergic, that is the commonest one. They diagnose as a allergic, though there are no urticaria, no pruritus, no allergen induced history. And then the appendicitis, as in the pediatric surgeons, non-allergic angioedema, and reflux, and hence abdominal peptic ulcer. Coming to the airway angioedema, which is the worst part one would think of, and the common age group here is as seen as early as 6 to 10 years, and then it peaks around 26 to 30 years of age, but you do see in pediatric age group and adolescents and pubertal age group as well. Here, looking at the deaths from asphyxiation, in 7 out of 527 in diagnosed patients and undiagnosed patients without having a confirmed diagnosis but features suggestive of HAE, their number is more. So the clinical manifestations commonly around the head and neck, that is around the face, then around the limbs, hands and legs, feet and genitalia. These are the common area where you see the edema. Sometimes you could see a serpiginous rash, what we call it as erythema marginatum in those children, but it's not a itching at all. It's not a typical hives where you see urticarial rashes. Submucosal tissue swelling, gastrointestinal upper respiratory tract infections can be missed and then the diagnosis as asphyxiation. So the triggers, what makes them to develop this? The common triggers are any surgical procedures, physical stress, emotional stress, trauma. You would see someone going to skiing and then suddenly developing, died. We don't know why. Someone attribute to the heart attack, someone attribute to the allergy, and it could be because of hereditary angioedema as well, because of the stress stimulates that. Minor trauma, surgeries, AC inhibitor, you all know that one of the common side effects, the known side effect of AC inhibitor is angioedema, and that makes it worse. Many episodes have no trigger as well, so no need to be triggered. So the frequency of the episodes, usually each episode lasts to 2 to 5 days with a little bit of prodromal and with the medicines. If you are spontaneous, if you don't give medicines, especially the peripheral edema, they will get better within 2 to 4 days, and the frequency gets worse as they grow. The deficiency of C1 esterase inhibitor, this is the one of the protein complement system. So it comes under the category of inborn errors of immunity, one of the type category 8, which is the complement defects. And among the complement defects, one of the disease is C1 esterase inhibitor deficiency leading to hereditary angioedema. And the C1 inhibitor deficient, then there is no break in the production of bradykinin from kallikreinin, because C1 inhibitor inhibits the excessive production and prevents the stimulation of the classical complement pathway. So the C4 levels, if there is absence of C1 inhibitor, C4, the complement factor, the pathway is activated and C4 goes down significantly. So increase in the bradykinin, blood vessels get dilated, capillary leak will happen, fluid accumulation, and then the angioedema. When you come to the types, there are 3 types. The commonest one is type 1, that is genetic, which is inherited autosomal dominant wise. Type 2, which is a qualitative, the C1 dysfunction is there. There is the quantity may be normal of C1, but it is not working well. So when you test, you do the functional assay as well as the antigen C1 assay as well. So the third category is C1 inhibitor levels are normal, genetics are negative, but hereditary angioedema with normal levels of C1 inhibitor. So that is, there are other mutations are there in that category. So coming to the type 1, you see the C1 esterase inhibitor levels are very low, less than 30%. And in type 1, the functional also, when the levels are low, of course the function also low. Type 2, the levels are normal, function is defective. That's why they develop these repeated episodes. Acquired, we don't see in children that often, but SLE patients, some sort of lymphoproliferative disorders because of the development of antibody to the C1 esterase inhibitor, you would see acquired C1 esterase inhibitor deficiency. In that, both INH and the levels are low. AC inhibitor and idiopathic where the levels are normal. So diagnostic, how do you diagnose then? When you're suspecting, the screening kind of test is just doing C4 estimation, which is easily available in Mangalore. Many labs, they do C4. It is commonly the rheumatologist request for a case of C3 and C4 for a suspected systemic lupus erythematosus child. So C4 level, when the C4 level is low, with the history similar, the angioedema different, with the history, with the no family history also suggestive, then you should further do the C1 inhibitor antigen assay and the functional assay also. If there is a C1q antigen, if it is defective, then it is acquired. If it is normal, then it is type 1 hereditary angioedema. C1 inhibitor functional assay, if it's low, type 2. If it is normal, then you call it as idiopathic. So As I said before, in more than there are case reports of normal C4 but low C1 esterase inhibitor, but that's all for the further research point of view. But majority of them, around 99% of the hereditary angioma type 1 disease will have low C1 C4 levels. That's why the good screening method. 3 treatment strategies for C1 inhibitor assay. So on demand, short term prophylaxis and long term prophylaxis. It's like a treatment for hemophilia patients. And on demand is whenever they develop these symptoms, treat those symptoms. Immediate management. So the immediate management to give C1 esterase inhibitor, the celestrase, the molecule which is intravenous molecule which is available, and other medicines you can give is epsilon caproic acid, the tranexamic acid, which helps in the preventing these episodes, and the anabolic steroid danazol, which is available in our country, which is easily available, that can be given also. Short-term prophylaxis for the procedures, some on the dental extractions or some other procedures, you give the short-term prophylaxis. Long-term, if someone requiring debilitating problems every other day or other week, admitting in the hospital and unable to tolerate pain, etc., they will require long-term prophylaxis. Long-term prophylaxis with the C1 esterase IV infusions twice a week is cumbersome. It's like a hemophilia-like patients, but that will make the change their life. So on-demand therapy, as already talked about, 2 to 10 ml per kilo repeated every 4 to 6 hours. That contains that's for the plasma if it is not available, because plasma FFP also contains C1 esterase inhibitor level. So if you don't have a celestrase or the C1 molecule, then you can give that. So the acute therapy always intravenous, not this picture is no intravenous C1 esterase inhibitor, and if that's not available, FFP. What are the recommendation? All patients should have at least 2 doses of therapy home. Trained self-administration. Many patients, children self-administer these C1 esterase injection intravenously as well, and a lot of problem with the long-term IV administration, cannulations. Some of them will admit having the portacath indwelling catheters as well. So this is the cartoon where you see that the contact activation. It's a kallikreinin system, plasminolytic system, coagulation system, and complement system. These are the 4 areas where C1 esterase inhibitor comes into picture, and that's why the activated factor 12A and then activate C1 to C1 the C1 esterase inhibitor comes into picture. If the inhibitory levels are low, then the complement is activated. There is no check on the complement classical complement pathway activation leading to low C4. And here the high molecular weight kallikreinin is metabolized into bradykinin, and that is not checked with when there is absence of C1 esterase, and excessive production of bradykinin lead to the vasodilatation. So this is the international multicenter prospective angioedema of C1 esterase inhibitor trial, done over 3 years, and looked into the safety and efficacy of this molecule in the impact 1, and also looked into the time to the onset of the symptoms to get better. So here the randomized trials, placebo-controlled open-label trials, and with the 20 unit as well as the 10 unit as well as 20 units per kilo, the administration, they found out, as you could see here, within the first hour, almost 75% of them they responded beautifully to the treatment, and there weren't any adverse side effects to the C1 esterase. That is so the time to get the onset of the symptoms to get better within 1 hour, but completely resolve it used to take around 15 hours. So this again the impact 1 study looking at to the side effects. There are not any statistically significant side effects noted between the placebo and the investigative medical product trial. So these are the safety trials. So conclusion that 20 unit per kilo is the safe and efficacious. This was the second trial, the impact 2, looking into the patient reported time to onset of symptom relief, and it used to be around, on an average, as you could see here, less than So a single dose effectively treated 99% of cases. As you could see, majority of them got better within 1 hour, less than, as you could see here, the time to onset of symptoms relief and time to complete resolution of symptoms also within 24 hours. And then they looked into subgroup analysis with the androgen, without androgens, the severity of the attacks, and as well as the site and etc. All of them got better within 1 hour and complete resolution within 24 hours. And with regards to the Celestrase product, which is the Intas molecule, which is freeze-dried molecule, comes up in the 500 unit vials with the readily available water for solution for dissolution, and 10 ml. So the 10 ml, when you dissolve it, will contains 500 ml. So you need to slowly give infusion. So 500 units of Celestrase, you give it to over 2.5 to 3 minutes. That is the recommendation, 4 ml per minute. That's around 3 minutes, 2.5 to 3 minutes. So you could give for all patients, including pediatric trials above 5-year-old. They have given these medications and have shown good response as well. Second dose is repeated 1 hour if there is no response, as recommended. During the pregnancy also it is safe, and because pregnancy also the episodes makes it worse. And pediatric use, there are enough studies to say that safety, efficacy, and the role of these medicines works well above 6 years of age. No patient developed inhibitory to antibodies. Like in hemophilia, we worried about whether to develop inhibitory antibodies, but for Celestrase, no inhibitory antibodies. To conclude, whereas the most cases of angioedema are mediated through the mast cells, allergen mediated, here it is not, it is bradykinin mediated. Type 1 and type 2 HAE result from deficiency and qualitative defect leading into hereditary angioedema. Type 3 is rare, but there are other mutations like factor 12 gene mutations, or it could be plasmogen mutations or kinin mutations. Probably that is the reason why they develop hereditary angioedema. Emphasis of the diagnosis is picking up, I hope, by knowing the condition, and hope we will pick up more and more cases. We will sensitize more and more people, and then we can start the right treatment for these patients. With that note, I would like to conclude. Thanks for patient hearing.
Thank you, sir, for enlightening us on one of the rare and serious conditions. Kindly correct your memento. Let us move on with the first panel discussion of the day, tuberculosis, a great mimicker.